evolving from say 1970s to 2020. Spoke to Pooja. She's also spending half her time in the OT doing hysterectomies and cesareans. All of us are basically gynecologists. So keeping that physical examination, analysis, hormonal evaluation of the man, which is quite unfair, I feel. But I think so. There can be low sperm count. There can be no sperm count. There are different ways to manage a low sperm count and different methods of handling when there's a delayed liquefaction or no liquefaction, hyperviscosity. There is a low volume semen sample, low pH. Has got some optics which we teach in the classes for long times. So there are phase contrast .com. So there are multiple causes: pre-testicular, testicular, post-testicular, sperm factors, and which I told you I'm not going to cover about these things today at all. I'm going to a different level. So we have a liquefaction, volume, color, pH, odor, viscosity, motility, viability or vitality, morphology. So to know the vitality of the semen sample, we can carry out things like this performs. This has around 10 years, and the next bulletin is being planned for year 2030, next 10 years. So then the main focus somewhere was cervical mucus intervention. Can't find such plates anywhere. New procedures for sperm preparation from analysis. Now coming to the 6th edition. Yahan par kya ho raha hai? That's very, very nice. Now look at it. 6th edition talks something bigger. It has become part of now. It is joined hands with UN-sponsored HRP, Human Reproduction Program. They are talking about SDG 3.7. Has anyone heard about SDG 3.7 2030? That's a goal.
Sustainable Development Goal.
Beautiful. I've written here. It's about the complete goal of that man, not only to impregnate a partner, not to get a pregnancy, not to have a good male contraception. It's about universal access to sexual and all those blah, blah, blah family planning. This means that it is becoming part of more global. It is no longer limited to semen analysis. It's going much ahead. It's looking further off, and it's got an aim of 2030 now, where it will become part of development of the man. So it's become part of it now. Initially, they were helping the development of the manual, but now it's become part of SDG. That gives it a lot of power to get that data in. And see, these are the people, I always say, they are worked very hard, and just showing the slide that it wouldn't have been possible without thanking these guys who have brought so much of knowledge to all of us. And if you get time, go to YouTube and watch the videos of WHO 2021. They are on, there's a video of around 1.5 hours. In case I'll send you a link of this video also. Must see this video. You will know how the things developed, and you'll be so grateful to these people. They're the doyens who have worked so hard. So Pehla launch was on 27th of July 2021. First launch came, they had a meeting, they had keynotes, and they also asked for any changes in the whole thing. They brought out a draft. Then they had some sort of a conference there, and there was no Indian. Till now there was no Indian there. They were all from Europe, these people, and from US, and they brought out the manual. And this manual is not thinking ahead. This manual says that we are not working like a pathologist. Normally, we work like a pathologist, where we write clinical correlation. They say there's no clinical correlation. We have to have we have to have limits, and we have to find out that normal and pathology. We have to move away from the pathology part of it, and we have to get the limits between normal and abnormal. So they talk about the decision-making limits, which we don't get from all these values. These values, they don't allow us to make a decision. They give us some pathology limit and we start correlating the things. So say that we have to define distinct limits. And the answer is that a man who's got a very good sperm count and is staying with his wife, the wife doesn't become pregnant, we don't take a semen sample. We say he's not fertile. On the other hand, a man who's got a low sperm count of 4 million, his wife impregnates. Then how do we do decision making? Where are the limits? So they say these two things are the wife can be lucky or the wife can be unlucky. The husband can be lucky and unlucky depending upon with a bad sample the wife impregnates. So they say this is not the right thing. Time to conception 12 महीने का is okay, but the population may be mixed and we may not get the right answer. So they are going one step ahead in making decision-making limits, not pathological limits. And for that, they are telling people to work hard, and the data will be probably coming out in 2030. So they say assess the male reproductive organ function. This is very important. Follow-up of andrological treatment of man. Assessment of male contraceptive measures. So what is the latest advancement in the male contraceptive treatment? Anyone? I just spoke about 𝙤𝙤𝙪𝙧. Do you think it can help us in male contraception? In case anything can block 𝙤𝙤𝙪 anic channels.
Calcium channel blockers can prevent the motility, sir.
Yes. In case the channels are blocked, there will be the male contraception. This man won't have ectosomal reaction, hypercapacitation, hypermotility, everything will go. So work is maximum happening in the world on 𝙤𝙤𝙪 channel blockage without causing any problem. It speaks about ART modalities of treatment. It speaks about the epidemiological and environmental studies. That's the way things are evolving. Way forward is 2030. Initially, the bulletin came in 1980. Then somebody wake up, 87. Somebody wakes up, 92. Somebody wakes up, 99. Then somebody wakes up in 21. In when 10. Then somebody brings out in 2021. But now it's a very deliberate move to 2030. Very, very planned way they're going 2030. And they're going to understand all these things. All these things. They're going to go in retrospect. Prospective studies are going on. In 2030, it's become part of SDG 3.7. They have to give you a proper answer. So all these factors, optimal treatment, ART treatment, optimal contraception, environmental pollution, whatever, blah, 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 everything is being covered. So the matter of standardization is here. They say global standardization has to be done to generate new diagnosis and treatment, generate robust data. Misinterpreted limits will not be used anymore. They want to come to some proper limits. They want to go, and then that's the way they want to go ahead. So look at this document. Initially, it was SOR, standard, optional, and research. So now look what they have done now. They say we have one semen examination, sperm preparation and cryopreservation, quality assessment, quality control. Here, 43 countries, 6 WHO regions, experts came. Look at how people are joining in now. In 1980, the first bulletin was actually brought out by around 5 people. They were friends. Now, 43 countries, 6 WHO regions came together, 3,500 subjects, 12 countries, 5 continents. They all came together and they gave this bulletin. And the plan is good clinical assessment, analysis, investigation and management of subfertile couple is the aim. And now the change which has come here is, as you can see here, small change has come. It's got these new terms. They call it BER. Initially it was SOR. SOR was standard, optional, research, and now we have got basic, extended research. So now basic means could someone please mute them? Somebody is talking. We have basic semen examination. Here we speak about simple analysis. Then we have extended analysis, and then we have research tests. So extended tests, basic is this, where like we have been doing before, we carry out the concentration, motility. So all these things. So in the basic examination,
please mute everyone.
in oxygen. So these are the few things. So basic means that we have concentration, motility, and morphology. Morphology is now 4% as per WHO criteria. So even if few sperms are present, we normally do the basic examination. They said no replicate assessment is required. Only one sample is good enough. Don't make multiple slides. Sperm concentration, which was initially taken as 15 million, has come down to 16 million now. This you have to know. So sperm concentration has gone up by 1%. The one change which has come. I don't know how it's going to affect us, but 1% is a change. Suggested said don't stop assessing a sperm even with sperm count as low as 1 to 2 million. Keep assessing, they say. Total sperm count into volume. This somebody told me. Total sperm count is total sperm in ejaculate into percentage of motility. These are the motile sperms. Or that's the way. So basically they multiply the motile sperms by the into percentage of motility or sperm concentration into volume of semen. So they are talking about the total sperm concentration now. This is important. And we speak about the, in case you look at this chart, the sperm motility, they speak on the, we are back to the 4-pointer system. We had gone to a term called progressive plus non-progressive and immotile. This is what we were using. It's called a 3-pointer system. But now we have gone back to 4-pointer system: rapidly progressive, slow progressive, non-progressive, immotile. So these are taken as progressive. Slow and rapid are taken as progressive in total, like this P combined. So more than 25 micrometers per second, 5 to 25 micrometers per second, non-progressive less than 5 micrometers per second, immotile, no sperm movements seen, and total motility is now 42%. This is the part. Initially, total motility was 40%, and now it has gone to plus 2%. And progressive motility initially was 32%, and now it has gone to minus 2%, 30%. So these are few changes which have been done. Sperm vitality, which was initially 58%, now it has become 54%. So minus 4% has come down. And morphology, in case you look at it, is at 4% only. So when you look at it, beyond basic examination, we have basic examination. Then we have beyond basic examination. Here we talk about damage, markers of genital tract infection, sequence of ejaculation has come here now. Lovely. So they are moving ahead now. Semen biochemistry, anti-sperm antibodies, they have kept it in beyond, but we don't do it routinely. Multiple sperm defects, aneuploidy assessment has come now. So as you see, we are now going towards, we are migrating up in the hierarchy with the experimental to non-experimental now. Research are ROS, acrosomal reaction, sperm chromatin structure and stability, Caspar channels and CASA. They are the research procedures. So what is discarded? All these initial tests which were part of the game in the first 3 bulletins or 4th bulletins, they were hamster egg penetration, sperm cervical PCTs, they are all gone now. This you have to know. Conclusion: basic examination focuses on stepwise procedures, evidence-based techniques, and they are supported by the new ISO standardized protocols. They said lists have to be developed. We no longer go by the pathology limits. So we have to limit ourselves. We have to unlimit ourselves depending upon the patient's multiple parameters and not by one parameter. And so we have to do standardization. This is their take-home message, and this is the how they look at the volumes in WHO 2020 when they started this thing. They are going by 5th percentile. You'll find that volume is 1.4 ml, gone down by 0.1 ml, concentration gone up by 1%, vitality gone down by 4%. Morphology remains the normal at 4%. So that's the way they're doing the things. And this is a comparison again. I'll give you 30 seconds break here. Just read the comparisons between 10 and 20. Please read it yourself. We won't talk. Just read it yourself. And also on the morphology, how it has progressed till date. This is a very important thing for you. And also, I'd like to bring your focus to the sperm number, and the volume, how it has progressed. To take around 30 seconds, read about this, and then I will move to the next slide. So a lot of things have been happening, and now we have to evolve to the newer protocols, and we have to also pick up the right things which are important for all of us. And now to summarize it, 5th edition and 6th edition, I want to just hammer in the information in your mind. I'm hammering in again and again. This is 5th edition. This is 6th edition. 210, 221. Change in the volume part, important. Change in the sperm concentration. Change in the morphology, there is no change. Change in the vitality. Vitality, there's a change which we can find. Change in the total motility and change in progressive motility. Some changes here. So now to redesign your semen analysis form, that is very, very important. And now this is again a very favorite slide of mine, where we are trying to compare the 5th and 6th edition. So before the 5th edition, we had standard optional research. We call it SOR. And here we have BR, basic, extended, and research. You'll find that many of the things which are present in the options here have migrated to the basic examination there. But they have now added, in case you look at it, they have deleted from this. Zona hamster has gone. They have deleted the zona pulsar binding tests. They have deleted the PCTs. New things which they have added now very formally is sperm DNA damage, as you can see here. Sperm aneuploidy assessments are there. Then sequence of ejaculation, it is there. And oxidative stress, sperm chromatin structure and stability, it has been added. Catspur channels and CASA has gone in the end. Initially, CASA was here. CASA was here. CASA has gone into research now. These are a few things which they have done, and I'm very sure it's going to benefit all of us in a big way. So that's it from my side. Whatever we do, whatever protocols we take, but time to pregnancy will be in the man who has got not only a good number of sperms, but good quality of sperms. For that, I think we should eat a healthy diet. To try to move to a rainbow diet in case possible. Have a lot of colors, have a lot of natural food without boiling them. Be a good child to your wife. That's I always say. Any man who comes home at right time, who doesn't party hard, late nights, drink less, will always have a better sperm count. Anyone who spends time at home with the family is going to have a better sperm count, because he'll be probably away from stress and unnecessary trauma. So good diet is important for us. Colors, lot of fruits, lot of colors, and stop carrying your mobile phone in your pockets. Normally we carry our mobile phones in our pockets, carry probably sometime. The man will be buying a Gucci purses along with his wife and carrying it in. Direct damage to the testes. And I think that's it. So in case we do things correctly, the sperm count can increase. Thank you so much. I've ended my talk. I've taken 1 hour. And I again request you to download this bulletin, which has been made by Dr. Yogesh. And you can download from the LinkedIn. It's available on the LinkedIn now. You would have already got the link. Just go down and click the button. You can download it. We also invite you to our next curtain raisers on batch IVF. Dates will be announcing very, very quickly. And second, next one will be on workstations in IVF. That's it. Thank you very much. I've taken around 35 minutes for the whole thing. Thanks for being with me. We touched a number of 310 today. So a lot of you joined. Thank you so much. I'm open to a few queries now.
Good morning, sir.
4% morphology is normal considered.
More than 4% is a normal morphology.
Is 96% abnormal morphological sperms is also normal.
Bilkul. 4% is normal sperms. We have 4% normal sperms. 4% sperms are fine. After by WHO criteria, your count is okay. When 4% normal sperms are there, we are sure that there will be the DFI will be less than 20%, and I think DNA damage will be pretty less in such cases, and they'll have more functional capacity. And it's an assumption that the sperms which have got normal morphology, less DNA damage, they'll be having more activated 𝙤𝙤𝙪 channels. The 𝙤𝙤𝙪 are also working well. That's
what
it.
Exactly meaning sequential ejaculation?
Sequential ejaculation means that we are focusing on retrograde ejaculation. We are now focusing on aspermias. We are focusing on hypospermias, hyperspermias. Initially, we were not focusing. See, when the semen sample is given, semen sample gets the maximum sperms in the first ejaculate. The second ejaculate, we have got more of glandular secretions. So initially, we were only focusing on the number of sperms. We never bothered went more than that. But now we are going into the low volume analysis, and we are investigating on hypospermias and aspermias and retrograde ejaculation. This is what it means.
So these samples are collected on the same day or consecutive days? I mean,
what samples?
You said first part.
Same day. When you give somebody a bottle, tell the man that the first ejaculate has got more number of sperms. The second ejaculate won't have. It'll have more of secretions.
Secretions, yes.
These sperms will come in the first ejaculate. That's the point.
Sir, very good morning. Thank you so
Hi.
much for your wonderful presentation.
Sir, Dr. Adesh here, a few questions.
Yeah.
So like always there has been a discrepancy between the semen analysis advancements and there's a gap between the management protocols. So how do you see that, sir? Because we go in-depth analysis, we have very limited medications. So how do you see that?
See, this is what we are again and again teaching in our classes, that there are only 5 conditions in the man, only 5 clinical conditions. In case you master them, you won't have any problem. These are all the clinical correlations. These are the pathology reports. So they limit our clinical decision making. So nothing can supersede clinical decision making. Clinical decision making depends upon the reading of the man. I think the people who attend the classes, they will tell that we normally nowadays tell how to read a man. Read a man, you'll come to know. We also talk about when you look at the man, look at his BMI, look at his internal health, look at his psychosexual health, look at his examine him, look at the testicular volume, look at his epididymis. So unnecessary, actually we are only looking at the sperm count. So until our clinical decision making will be hampered till the time we don't start looking at the man in totality. And for this, there are only 5 or 6 clinical conditions are there. In case we master them, I think it's a spotter for a man. It's a spotter for the man to come to a diagnosis. So the only point is that we want to analyze his sperm and carry out 𝙤𝙤𝙪 and CASAs. They are not actually required.
What are the 5 things?
Sir, when it comes to morphology,
you told, those 5 things in the man you want to see that.
I can't cover in this class now. Actually, can't cover. I've already covered them in the previous curtain laser. But it's basically examination, his BMIs, his internal health, psychosexual health. They are the ones which are important.
Good morning, sir.
Thank you.
I'm sorry. This doesn't fit into the preview of this class, so I'm sorry for this.
No problem. Thank you, sir.
Good morning, sir.
Yes. Hello.
Sir, I just want to ask that when we swim up the sperm, is there any chances that the sperm loses its capacitation or decrease capacitation?
No, no. When you do the plain simple swim up, there is no loss to its capacitation. When you spin, that's a time when there can be damage to the membranes and your catchment channels can be damaged. But on plain simple swim up, there is the best method to do. Like microfluidics, swim ups, they are the best method. Sperms will get capacitated the moment they touch the media. So there is no need to do any centrifugation. On the centrifuge, there's a problem. But in case you just take a sample of sperm, put some media and let them swim up, that is the right method. There is no damage.
Okay, thank you, sir. And sir, for break viscosity, can we use saline?
No.
Sperm wash.
Anyone? Can we use that?
Sir, we,
No,
yes,
no,
sir,
sir.
we use
Saline
media
means-
to break viscosity.
Why we use media?
It is washing media.
Osmolarity.
media.
Osmolarity is 280 milliosmoles. In case we take normal saline, the osmolarity may differ. So sperm cell will become an hypoosmotic swelling test for the patient.
Sir, simple 𝙬𝙤𝙪𝙧 also you can take.
Whatever we use, whatever we use should be sterile and the milliosmolarity should be same as the sperm cell. This is important.
So we use media.
You can use media. That is about 280 to 292 milliosmoles. You can use that.
Yes, sir.
I think one more question I will take. One or two more questions I will take. Yes.
Sir, when it comes to morphology testing, in the manual method, we are just looking for the Kruger's criteria. But when it comes to CASA, they are just checking up with the acrosome, the size of the head and the chromatin level.
See, I won't go into this. This is a debatable thing which you brought up, but actually, what do we have to see? Is sperm, when we do any morphology assessment, sperm head is looking at you. You can't miss that. Sperm tail is looking at you. Mid-piece cytoplasmic droplet is looking at you. There are many things, 6, 7 things. But most important is the proper staining, by which we look at number of vacuoles in the acrosome and the nucleus. So whole game is about looking at those vacuoles. What we do is, normal head means normal sperm. This is wrong. Select normal head, normal tail, normal midpiece, and after selecting it, those sperms you enter their heads now. So all the people who have done our courses, hands-on courses, and if somebody is there, I don't know. Or somebody is there who has come for our hands-on on semenology. In case somebody can tell us how you read the acrosome and the nucleus. So we have to stain them, and then under 100x, under oil immersion, we look at the number of vacuoles, the size of the vacuoles. So we can't make that out because we don't have such an equipment. CASA can do. But we know the number of vacuoles, their localization will tell us whether that head is normal or not. So normal head doesn't have any significance for me. Normal head I can see at 30x, but morphology is done on a fixed smear at 100x under oil. That's the time when you can see the vacuoles. Vacuoles in the acrosome, vacuoles in the nucleus have to be seen.
So Dr. Gupta here.
Hi.
I want to question regarding sperm survival test.
Yeah, Hanji.
Because there are lot many things that have been done for a test, and everything actually cost very much. So in a remote area like periphery, sperm survival test, how it will going to help it?
Very good. It's a very good test. Normally, when we have non-fertilization, so nowadays we are doing ICSI in all the cases, majority of the cases. So sperm survival test doesn't give us any much of marker. But normally when we were doing IVF, I think if you remember, when we used to do denudation after 24 hours or 18, 19, 20 hours, that's the time the sperms are moving. We felt very happy that sperms are surviving. But sperm survival test is a very good test. I think you can keep the sperms. Sperm survival test will tell you two things. It will teach you that your incubator settings are proper. that your CO2 is okay, pH is okay, media is okay. That's number one. It will also teach you the quality of sperms. But here, one big variable will come, that is of the incubator. You getting it, Dr. Gupta?
Yes, sir.
pH आएगा ना इसमें, pH आएगा, temperature आएगा, humidity आएगा. They are the things which are, they have to be normal for sperms to be normal. But in case your pH is calibrated, the CO2 is pH we don't do routinely, but in case CO2 is calibrated, temperature, humidity is calibrated, your VOCs are calibrated, then sperm survival test can be a very good test. Very good.
Because I used to do in a hippies, sir. Because for in a previously when I was don't having any IVF lab unit, I used to do a swim up and just keep the content in a 5 ml test tube. Check every 6 hours, 4 hours, and 12 hours. That gives me exactly the means cause.
Absolutely.
What should I do?
Absolutely.
Because in the periphery, sir, we don't have CO2 incubator. Most of the, I think, gynecologists, they also don't have it. Who was doing IUI, they don't have the CO2 incubators.
Very right.
Even the morphology is a subjective because no one exactly know how the actual sperm morphology shape is there. That what I have seen it, sir. Most of the even because gynec people they give the semen analysis outside outsources. Pathology lab technicians they do it. It's a very rare that very one go for IVF lab and they do it. This is a problem. That's why I find this way out of. कि भी हो जाएगा लेकिन कम से कम sperm जो survive हो गया, that will be going to give the pregnancy.
Yeah. नहीं, I agree. But इसमें ना बड़ा अब एक चीजें होती हैं. Sperm is a DNA fragmentation, maybe a live sperm. It may not die. It may not. So I think it's a pretty complex question, complex answer. But in case you want to do a proper sperm survival test, because HIPIS buffered media may not be able to maintain the CO2, may not be able to maintain the pH for a very long time in an open atmosphere. So in case you want to do a proper sperm survival test, we have to have proper conditions for these sperms. But yes, this is a good way, and I say not 24 hours. You can do it easily for 36 hours.
Yes, sir.
36 hours sperms are alive. So you can do that. Nothing wrong in it. It's a good innovative thing and it can be done.
Thank you, sir.
One more question, one last question, then I have to go to my OT.
Okay, sir.
Thank you so much.
In diabetic patient, how routinely we do the survival test, sir?
Diabetic patient के अंदर DNA fragmentation कीजिए. DNA fragmentation is pretty high in the diabetic patients. They have got ROS and they have got high DFI. Cure diabetes, HbA1c control कीजिए for around 2 to 3 months. Give them antioxidants. Coenzyme Q is the right treatment choice for them. Coenzyme Q I given good amount, 300 milligrams per day. Some multivitamins, and I think then it will be corrected. So cure the diabetes by controlling the HbA1c. It will take around 2 to 3 months, and then you go in for IVF or IUI. In case you are doing IVF, IUI or ICSI, I prefer you should go in for a microfluidics. You correct the DNA fragmentation, correct HbA1c. Still, I don't believe it because I may be picking up the wrong sperm on ICSI. Do microfluidics and ICSI. That's the take-home message for a diabetic patient.
Thank you, sir.
So I think I'll say goodbye. So it was wonderful having I forgot the doctor from who won a chocolate cake. Who answered about catspert genes.
Dr. Hardy, sir. Dr. Hardy from Nagpur.
So tell him to send me a message. I'll forget my
Details to you.
address and pin code, exact pin code. That's very important.
Yes, sir.
Thank you, Krishi.
Coenzyme Q level, how much, sir? 300?
Yeah, no, ma'am. Some people give 100 unit milligrams. I give 300. Some people give 300. But give coenzyme Qs are very important for ROS patients.
Sir, in our part, most of the these technicians or pathologists give a sperm morphology 50%, 60% normal. So how is possible? If 4% then how is possible 58, 60% are normal?
Sample 30% higher weight we are reading, but in outer labs they are giving a 70% normal, 80% normal sperm morphology.
They are not doing it, ma'am. So morphology means it is a fixed smear done at 100x, stained smear under oil immersion. This is a minimal criteria to do it. So people don't do it.
Okay, sir.
So
Thank you, sir. Thank you so much.
For morphology.
yes,
48.
morphology.
Okay.
So please send me the details of Dr. Hardy, please. Don't forget with the pin code. And thank you so much. And I will invite Dr. Pooja back to say some of the session in case she is there. Dr. Pooja Shah.
Yes, sir.
Madam, you can just sum up the day. Thank you so much for being with us.
Thank you so much, sir. The lecture was really nice.